We're going to just read questions off of these cards and try to figure out who the best person is to answer some of these questions. So first question is, what if I don't have diarrhea but am the total opposite, severe constipation?
Okay. Well, first thing is this. And I'm saying this at a cancer conference, kind of dangerous thing to say. We use way too many narcotics in America. 5% of the world's population uses 95% of the world's narcotics. Okay? So first thing I'd say is, could you do with a little less narcotic if you're using narcotics? Okay? Because that's probably what's constipating you. Okay. Then the other thing is you'd have to ask, that requires another kind of a complex workup. Okay? Everybody just assumes that when they have constipation, the constipation is due to what's called slow transit or things just not moving through. Half of constipation is not, this is not the conversation we're going to have before lunch, but I will press on regardless. Half of constipation is not due to slow transit, it's due to the poor mechanism of you actually expelling the stool. Okay? So, if you were to look at what the latest guidelines from the GI societies talk about, they would say that you ought to do what's called an anal manometry to make sure that everything there is working the way it should, and it's not simple, and some other studies as well. So you got a couple of different types of chronic constipation too. You have the person that comes in and says, puts on 10 pounds over the holidays and then comes in and says, I have all this kind of trouble bloating and I'm having trouble going to the bathroom because their pants are tighter. And then you have the person that comes in and says, I have a bowel movement about once every 3 weeks. Okay. Well, that's the one that you really want to work on. And that would require a workup, and you would go through the differential diagnosis and treat what you found.
Okay, here's one for me. You mentioned molecular profiling to possibly identify biomarkers. At what point would you recommend doing this? All stage 4 cancer patients? What about patients with no evidence of disease, post-surgery in hopes of monitoring possible recurrence? If this is standard practice after resection, has there been significant progress made in the past years to request further testing? Assuming tissue is still available, I was told it needs to be kept a number of years. So, for people who have stage 4 cancer and who have active visible disease, I do think for sure those patients need to have molecular profiling because it's likely they'll need ongoing treatment, and the treatments that are currently available will probably at some point not work anymore. So it's nice to know what options are out there. As far as people with no evidence of disease post-surgery, I think that it may not be necessary at that time. If there's no need to treat, then it doesn't make sense, taking the time and spending the money to do the molecular profiling. So I wouldn't do it on everybody. I would only do it on people who have active disease, and those are the stage 4 patients. Has there been significant progress made in the past years to request further testing? I'm not sure what that means. But, as years go by, we discover newer biomarkers, and the panels that these companies do when we send them tissue will change. So if 5-10 years pass since the last time you had molecular profiling done, it might be worthwhile to rebiopsy and retest because you'll have more biomarkers potentially, and the cancer itself may change after treatment. So it's not a one-shot deal. It may be worthwhile to do it again down the road. Assuming tissue is still available, yeah. Usually tissue is kept frozen for many, many years and is available. The key issue is the amount of tissue that you need. You can't really test on a fine needle aspirate, just a needle stick. It has to be a substantial amount of tissue to do the appropriate testing.
me see. Here's one. So somebody asked, how can you find out if your tumor has somatostatin receptors? So the tests we talked about, so Octreoscan and the gallium-68 PET-CT, what they target on the tumors are those somatostatin receptors. So if you were, and your tumor may not be positive, but that is how they figure out the level of somatostatin receptors on your cells, and it can help determine the treatment, because if there's no somatostatin receptors on your cells, then some of these somatostatin analogs are not going to work because they can't bind on the tumor. So those are the tests that they use to figure out a level of somatostatin receptors on the cells. The Octreoscan, or the preferred kind of newer test, although it's not widely available, would be the gallium-68 PET-CT. And then they also ask, can you lose your receptors after many years of taking octreotide? Which I don't know that the octreotide would cause. I don't know if that's known, but I don't know that it would have necessarily an effect on making. There are medicines or things that can happen that will increase or decrease receptors on cell surfaces. I don't know what effect octreotide would have on that, to be honest. I don't know if it's known, but and I also think I'm not sure that there's a lot of studies on long-term patient, like maybe side effects you might get with long-term octreotide or health effects with that. Carrie Bentro was just asking me this the other night. But so I don't know the answer to that. But I think that, it's one of the areas I think that might be kind of a future of research, with patients on these for longer and longer time periods. Maybe not what it does to the receptors, but what possible long-term side effects are and how those change versus short-term. So, but good question. I don't have a great answer for what happens to the receptors on octreotide.
I have a question, kind of goes along with that. Does lanreotide cause slow digestion of food, sour stomach? One of the other indications for those type of drugs, the somatostatin analogs, is rapid gastric emptying. Also, pancreatitis sometimes is treated with that. Basically, it tends to shut down the motility through the GI tract and a lot of the secretions into the GI tract as well. So, yes, it can cause what you would refer to as a sour stomach. But what that really is if you really look at the function of the GI tract, it likes things to move through there at exactly the right speed, all right? If they go through too fast, then you get gas and diarrhea. If they go through too slow, you get nausea, vomiting, and abdominal pain and distension, okay? So whatever you do that affects that will also cause the symptoms to go in the other direction as well. So what will happen is, when you eat, if you're taking octreotide, your stomach is going to empty slower. You'll have more nausea and more distension after you eat. The answer to how to treat that is to eat smaller meals more often, which is difficult because socially we like to sit down 3 times a day with everybody and eat. However, if you could do 6 meals and half the size, you'd give your stomach a lot less work to try to get that meal out than you would. Liquid makes your stomach empty better as well.
So I have one question that was directed for Dr. Iannetti, but I will try to answer it. Should a patient request a consultation with a surgeon about possible surgical treatment options, or assume their oncologist is either consulting with a surgeon or would know best when to refer the patient to a surgeon for liver mets? That's actually a good question, and I've come across situations where I've seen patients that were treated elsewhere and came to me for a second opinion that certainly did have surgical treatment options, and a referral wasn't made. So the answer is it never hurts to see a surgeon and get an opinion from them. And I wouldn't assume anything, and I wouldn't assume, frankly, that any doctor is always right. Be your own advocate and ask the appropriate questions. And if you don't get the answers that you think you should get, then seek other avenues. So the answer is no. Don't assume that your oncologist is consulting with a surgeon, and seek an opinion. It doesn't hurt.
Let me just add one other thing to that, too, only because I'm the one who deals with the complications of this. All surgeons are not created equal, okay? If you have a pancreatic tumor, you need a pancreatic surgeon who does 30 cases of pancreatic operations a year, preferably 30 Whipple procedures a year. Sewing the pancreas together is like sewing, if you've ever cleaned any fish, roe. It's very hard to get it to stay together and to get it so that it maintains its patency. If it doesn't, you'll have a lot of pretty severe complications. So that if you have a problem in your pancreas, you want to see a pancreatic surgeon.
To go along with that, some of the patients I've seen have seen a surgeon. The surgeon has told them surgery is not possible when, in fact, in the hands of a specialist, it is possible.
And this is something kind of along the lines of treatment and a couple of questions just about PRRT. So, should PRRT be a first-line treatment for medical therapy? When should you consider PRRT, and asking about the likelihood of PRRT approval, when that's going to happen. So, I think kind of along those lines, the NETTER-1 trial was in very narrow circumstances. And so, where it's going to fit in the treatment paradigm in America is something that's going to have to be worked out. I don't know, maybe you might want to, again, that's, and unfortunately, I think there's, because of this is a very heterogeneous disease, the treatment patterns are heterogeneous.
Yeah, the honest answer is we don't know. We don't know where it fits. It's nice to have a treatment option, and I think it should require a multidisciplinary approach. You need to get opinions from an interventional radiologist, surgeon, medical oncologist, and as a team, try to devise a plan. Like you mentioned, this is a very heterogeneous patient population, heterogeneous disease, but a multidisciplinary approach is of utmost importance to help determine what's the best first avenue of treatment. And it's going to be different for different people. Nobody is exactly the same, obviously.
There's a little trick you could use to know whether or not you've got the right people or to know whether or not your doctor's talking to other doctors. Ask him to discuss your case at Tumor Board. Okay? What Tumor Board is, it's a group of all of the doctors who treat cancers, all right? We get together at our hospital once a week, and it's televised between 3 different hospitals, okay? And most of the doctors are attending that on a regular basis. If you ask your doctor to present your case at Tumor Board and he says, well, we can't do that, then he's probably not tied in as well as he should be.
Yeah, and I would say, for some of these things that deal with approval and when it's going to be approved and who's going to pay for these things like that, change on a weekly basis. Yeah, and it's not an area. It's an area I find I don't like it. It's just talking about it's because it's not taking care of people, right? It's politics and money. But the Advanced Accelerator Applications is a company. They're here today. They have a representative, and now if you're very interested, the reason why to talk with them is because they are very up to date on the process where it is. They're probably now that NETTER-1 was released, I think places are putting in for applications to use it in different circumstances than what NETTER-1 covered, and so they would know people who have contacted them about obtaining the lutetium, so areas of the country where it might be, and maybe giving you an idea of how that's going to play out. But that's going to happen. But I think, it's going to take time, to work out how it fits into the treatment paradigm. And there's not going to be any great answers, and it's going to take time to get, higher level data to satisfy doctors and regulatory agencies in the United States.
Okay, here's one. Should a routine colonoscopy have shown a tumor in the tip of the terminal ileum? By the time my carcinoid was diagnosed, it had metastasized to the liver. Okay, well, in a routine colonoscopy, I'll give you a little bit of nuts and bolts on colonoscopies, all right? It doesn't make your colon cancer risk go to 0. It only reduces it by about 90% if you have a good prep and the procedure is complete, okay? So it's not perfect even finding the disease that it was designed to look for, which is colon cancer, okay? That would be one thing you should be aware of, preferably before you do your prep, because after you do your prep, you're going to sign the consent pretty much regardless. Okay, in terms of your carcinoid tumor, it depends where the carcinoid starts from. There are very specific guidelines on how to treat a carcinoid that can be found in the mucosa, or the inside surface of your colon, in the rectum, or further up in the colon. It is not routine on a colonoscopy to go into the terminal ileum or the bottom of your small intestine unless really typically you're treating something like Crohn's disease or that where you're worried about what that might be. Now, if you came in with a diagnosis of chronic diarrhea, part of the workup on that is biopsies from the terminal ileum. However, it would have to be distal enough in the bottom of the terminal ileum. You're only going to get about that far in, and it's probably 4 or 5 times that length at least. Okay, so it would have to be far enough down for you to see, and would have to be on the inside, not on the outside of your small intestine. So really the answer is, unless you have the pathology report that says this is exactly where it was, and you have the colonoscopy report to look at to see was there an indication to do it, you won't really know that answer. That's a pretty far reach, though. I would say it would be very difficult to find a neuroendocrine tumor in the small bowel before it metastasizes.
So a question about being a specialist in this. With neuroendocrine tumor being a less common cancer, what should a patient look for in an oncologist, both for a patient with stage 4 NET or a previous NET patient who is presently NED, no evidence of disease? Would you consider yourself or any other local oncologist one that specializes in NET cancer? Well, I'm biased, I think so, yes. It's, like we've talked about, this is a unique disease, and I think it requires a certain level of expertise. You have to have seen these patients before and frequently. More importantly, you want to see an oncologist or any specialist who recognizes their limitations. We don't know everything. We don't even come close to knowing everything. And you want to go to somebody that will tell you, look, I don't know, but I will find somebody for you who does know. And I do that. I do that all the time. If I don't quite understand what's going on, I'll say, hey, how about we go see so-and-so? They may have some other ideas. So again, I think it takes experience, but also a clinician who recognizes their limitations, and obviously you need to be able to trust them. I think I'm pretty good at doing this. I think there are other people in town that are as well. We use a multidisciplinary approach, like Dr. Iannetti outlined, so it's not one person driving the ship. You get different viewpoints, you get different opinions when your case is in our system. So, hope that answers that.
There are a couple of, there are a couple of questions on gallium-68. So, asking it if you get a gallium-68 scan at baseline and that's established, how do you do follow-up imaging? And that's a good question. But I think the consensus now is that, obviously gallium-68 scanning has not become widely used in America yet, because it's still just approved and people are just ramping up their programs. It's a little complicated to get it off the ground and running. But I think the way it's probably going to play out is that there'll be a strong push towards baseline scanning for gallium-68, and then monitoring response to therapy, or after that, probably CT scans, just because they're less expensive, more widely available, and I wouldn't say easier to do, but certainly faster to do. So probably, follow-up imaging is going to be with CT, and insurance money is going to have a concern with that too, because there's no way an insurance company would pay for repeated gallium-68 PET CTs. But and they probably don't need to, because I think surveillance imaging could be with CTs or MRIs or standard stuff, and then using the gallium scan if there was a problem, like if they had rising tumor markers or symptoms, but the CT scan was negative, then you could repeat that and see if there was some metastatic disease you're not picking up on. And then another question: if your primary tumor is not showing somatostatin receptor activity, what is the best imaging to use? And like I mentioned, sometimes these are very heterogeneous tumors, and so some will have them and some won't. it is the case that some of the more aggressive tumors don't have somatostatin receptors. And so those more aggressive tumors behave in some cases, if they are very aggressive, and that's why they don't have them, those can be tracked with PET-CT. The FDG PET-CT, like they do for colon cancer or lymphoma, can give you an idea about the metabolism of the tumor and how it responds to therapy. But also just standard imaging methods, which are still very, very good. I mean, it's not like, PET-CT changes gallium changes your treatment management, but not in like every case. So, still modern day CT/MR imaging for staging and follow-up is still very, very good. It's just, with the PET-CT, we can do an even better job. So, I kind of addressed this. Oh, and there was one specific question just asking at Moffitt Cancer Center, is there a multidisciplinary team? And that's what, at Moffitt also, these tumors are treated, tumors of all types are treated in a multidisciplinary fashion. So, particularly with neuroendocrine tumors, there are dedicated people who see a high volume of these patients. John Strasberg is he's a very well-known medical oncologist, handles a lot of the medical side. There are other medical oncologists who do a little less volume, but there are surgeons who they do very, very complicated liver and pancreatic and biliary surgeries on a routine basis and get good outcomes with minimal, complications. We have specific tumor boards for GI tumors, and then a specific liver tumor board where it's not just, it's surgeons, it's interventional radiologists, it's diagnostic radiologists, it's medical oncologists all together discussing the most difficult cases and that kind of thing too. Maybe not every case gets discussed in tumor board, but from those relationships and from that mentality, if you're in clinic and you have a patient, you quickly consult. Everybody's in one area all together, so they can talk on the fly without necessarily having a formal tumor board. So yes, that is how things are approached at Moffitt, with a lot of people who spend quite a bit of time specifically doing neuroendocrine tumors.
Okay, lab test quality at various labs different in reliability. Well, first thing I'd say is that you get sort of an impression that when you see a number on a page in a lab report out to 1 or 2 decimals that it's real accurate. Okay? And the answer is that's not always true. Okay? But that doesn't really mean that you have to be concerned about that all of the data that you had is not really telling you what it's supposed to be telling you, or that it's inadequate. Okay? What it means is that you have to keep in the back of your mind about the plus and minus of that. For instance, okay, it's not so much related to neuroendocrine tumors, but a lot of times they will call me if a patient is bleeding real badly, and I'll put the scope down and try to stop the bleeding. And one of the most basic labs that you check is a hemoglobin level in your blood. In a man, it's about 14, and in a woman, it's about 13 grams in a healthy person. Well, that lab test, so we'll be checking that every 6 hours. That test itself, which is probably one of the most basic, is only good to about plus or minus 1 gram. Okay? So we can't sort of sit on the edge of our chair and say, oh, dropped half a gram, we're still bleeding. Okay? But on the other hand, that is what we're using to make that determination, the same thing as what you all are using. So it's sort of like anything else. You just got to kind of watch it, and you have to look for a trend in it and sort of go from there. And that also leads me into the next question on this card. Is octreotide for symptoms only, or for anti-tumor? And the answer to that question is it has an anti-tumor effect as well. Okay? It is used for symptoms as well. It's also used for multiple other causes. One of those, an upper GI bleed in a patient bleeding with cirrhosis. So you do have some chemotherapeutic effect from that.
Yeah, I mean, there's data that suggests that you get anywhere from 5 to 10% of patients will get shrinkage of the tumor with those agents. It's usually not dramatic, but there are some people that actually get tumor shrinkage with depo-octreotide for sure, and I think we see the similar effect with lanreotide. Let me answer a few questions, and unfortunately I have to run back to the hospital. Are there treatments for carcinoid cancer that would prevent you from being able to have PRRT? PRRT involves radiation, and sometimes we do what's called radioembolization to the liver with little beads that are radioactive particles. And I would guess that if that has been done to your liver, it might make it less safe to have the PRT. And I guess Dr. Morse could comment on that as well. But that's sort of the only thing I can think of that would could prevent you from having the PRT. How to deal with large amounts of small liver tumors when the primary has never been found. There are a number of treatment modalities that we can use with liver disease. I think it's important to recognize if the tumors in the liver are actually growing. They could be stable and not require immediate treatment. But large amounts, I don't know what that could mean a lot of things, but microwave ablation, surgery, chemoembolization, radioembolization, PRT are all potential treatment options. But again, sometimes treatment isn't required if the cancer does not seem to be behaving aggressively or is fairly stable. And then I'll answer one more question. Low dose naltrexone, good or bad? There is some anecdotal evidence with naltrexone. I don't know what to make of it. It's probably not harmful, but it's probably not helpful. It's not been studied very much. It's not something that I would recommend in the absence of any data.
Yeah. I wanted to add one other story, if you could have the patience with that, about the question about Moffitt Cancer Center. You're talking about, well, first of all, I tell you, if you're at Moffitt Cancer Center, you're doing fine. The person who I originally learned about carcinoid tumors from was at Moffitt, and I was standing in the clinic room waiting for my attending physician to come out of the room so I could present the next patient. And this gray-haired guy with big gray beard, looked like Santa Claus, is standing there. He was Larry Voles, he's the guy who came up with using octreotide. So I had heard that he was Mr. Carcinoid, so I asked him about that. And this is right in Moffitt's clinic. And he came over and said, well, he said, I have carcinoid. And he said, so I had been kind of experimenting with with octreotide, and I had a couple of studies out, and they sort of knew I was using it, and they were doing a surgery on a big tumor in the pancreas, and they got into a serotonin storm, and the patient was basically dying on the table. So they called him, and they said, come on over, and the family has said that they'll take the octreotide because of the condition of the patient, and they basically waived all risk. And this was back in the day when you could actually do that. You'd have a much harder time today. But he went over, gave the patient the octreotide, saved the patient, and so that's what's coming out of. He started Nanette's. He's had a big point in starting this organization, and so whoever's at Moffitt, you're in a great place. Other questions that I have. Serotonin builds up at night, which affects blood pressure. Any way to combat that besides just somatostatin, diet, fluid intake? What I would say is yes, but it goes for all blood pressure, all right? It has to do with salt. The less salt that you take in, the less water fills up your blood vessels. Your blood vessels are just like any other container. You pack more stuff in there, the pressure inside the container is going to go up. If you eat a lot of salt, you're going to take that salt into the blood vessel, and the fluid is going to follow the salt because your body likes to have everything in exactly the right level, and then you'll have high blood pressure. Probably a lot of the people out there who have high blood pressure today in America, if they would limit their salt, would actually not need the medications that they're on. So that's one really relatively simple way. The other thing is, I would say to remember too, you have cancer, all right? So if you're talking about blood pressure, a high blood pressure of 145 over 90, that's not the same thing as 200 over 115, okay? So maybe you don't need to worry about it so much if it's on the high normal end, and there's probably other issues you have that are more pressing. Okay, is there a medical test to determine what dosage frequency of somatostatin you should prescribe to the patient? Well, first thing is I would say is there's not really a medical test unless you call listening to the patient a medical test. The patient will basically tell you what they need when they're sitting in front of you, depending upon what their symptoms are. And for the most part, when you're going to start out a patient on a new medicine, I don't trust myself to remember the doses of the medications that I prescribe. So I couldn't even tell you that this is the standard octreotide depot dose per month. I look it up every time, and we would set them up to get that. And then I would follow them up in 4 weeks and say, how are you doing? Okay. I don't know too many of my patients that would say that we're going to let you give us that shot every 2 weeks. Like, there's a lot of drugs, Remicade for Crohn's disease or that, where you could go give it more often, and that's fine. I don't think the patient's going to tolerate a depot injection more than once a month. So I don't necessarily know that I would change the frequency. What I would do is there are enough medicines out there now that I would probably add something else on if that wasn't adequate enough. And generally speaking, too, if you give the patient adequate dose, they're going to be fine for a while, and they'll come back and say, I'm much better, and then done deal, until they get enough tumor growth that doesn't work anymore.
Somebody asked about a different kind of nuclear medicine tests, an MIBG scan. So, there's multiple nuclear medicine tests other than just, Curie scans and gallium-68 PET-CT. They all kind of work on the same concept of linking up radioactivity to some kind of molecule that's going to attach to certain types of cells or tumor cells to locate those in the body. And so, specifically, they're kind of wondering if it might show tumors that don't show an octreotide or gallium. Now, MIBG can show uptake in certain kinds of neuroendocrine tumors, not at a variable level, depending on the primary tumor. And another caveat to this is in Europe, they're far more advanced in terms of the radioisotopes they use for imaging neuroendocrine tumors than we are here. MIBG was sort of one of the it's kind of an older agent, and it's used more commonly in the work of things like pheochromocytoma or some of these neural tumors, different from neuroendocrine tumors. It's not something we use extensively. I'm going to cop out a little bit because I don't want to say something that's wrong, but because I'm not sure if you have one of these patients that doesn't have enough somatostatin receptors, because it's not binding to somatostatin. So if you want to know if that might show some activity in your scan, if it doesn't show on a octreotide or a gallium-68, I'm not sure. I'm going to say with a disclaimer that I don't, probably not. But it would depend on is it a definite neuroendocrine tumor, or is it a possibility it could be one of these other neuro tumors of neurologic origin like pheochromocytoma or some of these other things like that. So it's a little complicated, but in terms of it's not something we use in routine imaging for most of our neuroendocrine tumors. So it works on a different receptor other than somatostatin. So it's a little incomplete because I would have to research that a little bit to give the most complete answer possible. But two other questions that are kind of related, and that would wrap it up for what I have here. The specific radiation dose for gallium-68, and one thing, the radiation doses I showed, those vary from site to site. So as the concern of the public and professionals about medical imaging has grown, vendors who make these CT scanners all have some really tremendous technological improvements to get the best images possible by lowering the radiation dose. So those doses I showed, in my opinion, are a little liberal. Probably what you're going to encounter, a lot of good practices are even lower levels than that. And so when I talk about a CT scan, radiation dose, it's going to vary from place to place. So these are ballpark numbers. And so, I had a hard time finding a good ballpark number for a gallium-68 PET-CT. And to give you an idea, Moffitt, it's an excellent place, wonderful place for neuroendocrine tumors, and even at Moffitt, we're just getting the gallium-68 scanning off the ground now. We're starting to do it just now. So, and this is not for a medical indication. This is because we're kind of getting some pushback from administrative type stuff like reimbursement and would they. It was nothing to do with. We knew it was medically indicated, but there was a hard time, administrative and financial hurdles to get over. So, so I can't go to my nuclear medicine guys and be like, hey, what's the radiation dose for our PET-CT? Because we're just getting it off the ground now. But it's less than that Triascan, and the numbers I was finding for our Triascan, ballpark, 12 millisieverts or so.
So it's a lower radiation dose than what you would for octreosine, to give you some kind of an idea of something you might be comfortable with. And another question about yttrium-90 therapy for liver metastases. So side effects, and is that effective? And is it effective is another one of these complicated questions, right? Because there are so many different variables that it's not a yes or no answer. But yes, it can certainly be effective, but is it indicated in your case? Would be one question, and because but I can't address whether or not whether or not to use it would be a question for a multidisciplinary evaluation. But the potential side effects could be, you can get damage to blood vessels from the procedure. You can get non-target tissue irradiation where some of the particles get in an area they're not supposed to be. There can be damage to the bile ducts. You can get an abscess afterwards. You can get pain after the procedure, irritation of structures adjacent to where the radiation is placed. And sometimes a long-term side effect, if maybe too much radiation dose was used in some cases, is that you can get shrinkage of the liver parenchyma. But in general, these are things that happen fairly uncommonly, and even more uncommonly in experienced hands. But those are some of the potential things that could happen.